Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the organizing committee for inviting me to be one of the speakers today. And of course for Mr. Adnan Al-Mousa and Akram Al-Ajmi and for all the people who are working behind the curtain for this Saudi group of technologists. And I totally agree, we are the bulls. So we will talk about introduction, background of echo, recommendation for the echocardiography assessment of LV size and function, tutorial how can we perform 3D full volume and global longitudinal strain, and take-home message. The quantification of cardiac chamber size and function is the cornerstone for cardiac imaging with echocardiography, being the most commonly used non-invasive modality because of its unique ability to provide real-time images of the beating heart, combined with its availability and portability. And like any area in medicine, we should go back to the founder of this area. This is Dr. Idler, who did the first MOD in 1953. Then his work was carried forward by the cardiologists all over the world. For his landmark discovery, Idler is recognized as the father of echocardiography. And this is Christian Doppler, who was an Austrian mathematician and physicist, well known for a principle called Doppler effect. So if you go back to the echo as a leading modality of imaging, it has a long journey of success, starting from A mode, M mode, 2D, and now we have 3D. And the Doppler that we use it nowadays, we start by blood ball Doppler, then we have tissue Doppler that we use it nowadays in diagnosis most of our disease, and now we have speckle tracking. And this is the latest American and the European guideline that was published in January 2015 about recommendation for cardiac chamber quantification by echocardiography in adults. And they talk about the standard and the normal value for all four cardiac chambers. In our presentation, we will cover how can we assess and quantify the LV function based on this guideline. So how do we assess LV function? Shall we assess it by eyeball? Yes, we can, but it will be qualitative assessment, it will be subjective, experience-dependent, lack of standardization, and there is large inter and intra-observer variability. So the recommendation for echocardiography assessment of LV size and function, it's internal linear dimension, 2D guided linear measurement, biplane disc summation, endocardial border enhancement, global longitudinal strain, and 3D datasets. So the first recommendation is internal linear dimension, M-MOD. M-MOD or motion mode provide one-dimension view where a single scan line is placed along the area of interest. The M-mode is then show how the structure intersected by the line move toward or away from the transducer over the time. It has good temporal resolution, so it's useful in detecting and recording rapid movement structures such as a heart. It's commonly used for measurement chamber dimension, calculating fractional shortening, and ejection fraction. So it has advantage that it's reproducible and has high temporal resolution. And it has disadvantage, beam orientation frequently off-axis, rely on the assumption of fixed geometrical LV shape, ellipsoid, which doesn't apply in all cardiac pathology, like if we have coronary artery disease or conducting abnormality. And how we will do the measurement? We will do it in parasternal long axis view. The scan line is placed perpendicular to the LV at the mitral valve leaflet tip. So when my scan line is perpendicular around 90 degrees, I get 66 ejection fraction, but when my scan line is not aligned around 120 degrees, I get 59 ejection fraction, so I underestimating the ejection fraction. But the latest recommendation in the guideline tackles and Conion method for calculating LV volume from LV linear dimension are not more recommended to be used in a clinical practice. Second recommendation, 2D guided linear measurement. So when we cannot align our scan line perpendicular in the septum, it's recommended to do the measurement directly on 2D views. The third recommendation, biplane disc summation, where we will measure the LV volume by tracing the endocardial border or blood tissue interface. Then the LV will be divided to 20 discs. So each disc will be 1/20 of the entire volume. And it's very important to match the length of LV in apical 4 and apical 2 chamber view in systole and diastole, because the machine will take one disc here, for example, and it should be matched exactly the same disc here. And then the machine will calculate the volume for each disc or each cylinders. Then the volume of the 20 discs will be added together to get the entire volume. And the machine will calculate it by the formula LV in diastole minus LV in systole divided by the LV in diastole. We will end up getting the ejection fraction. And this is the latest update for the normal range for the ejection fraction. For the male will be between 52 to 72%, and for female between 54 to 74%. Usually the female has higher ejection fraction than male because of their active lifestyle. The fourth recommendation, endocardial border enhancement contrast agent. Ultrasound contrast agent, it stabilized gas microbubbles sized to pass through the smallest capillary. So they have to be in a size range smaller than the red blood cells. So the microsphere size range between 2 to 8 micrometers, while the red blood cells between 6 to 8 micrometers. And what is the ultrasound contrast agent made of? They are microbubbles, which has a shell and a gas. And the majority of the gas is air, and small portion is perfluorocarbon class. And there is new European contrast agent, Soneview, they use sulfur hexafluoride. And the shell either lipid as in Definity or albumin as in Optizone. And clearly, contrast agent should be non-toxic, small to pass through pulmonary vasculature, persist enough to reach the LV myocardium and withstand the left-sided pressure. And this is the only formula that we need to know when we are doing contrast, mechanical index, or the power that comes out from the transducer. Mechanical index is peak negative ultrasound pressure divided by the square root of the frequency of the incidence beam. And this term is always in your machine, so if we are doing contrast, we should keep our mechanical index low, less than 0.3, and we use it with harmonic frequency. Because if we keep it high, like for 2D, it will destroy the microbubble, and we will not get a good result. And what is the advantage of using contrast? Is helpful in patients with suboptimal acoustic window, helping in quantification of LV volume and ejection fraction for better visualization of the cardiac apex. And it has disadvantage acoustic shadowing in the LV basal segment when we have high concentration of the contrast agent, and swirling artifact when we have poor opacification at the cardiac apex, and we can improve it by either reducing the MI or increase the rate of the injection. So this is the first case, 55 years old female has cardiomyopathy, referred to our lab to rule out LV clots. So in apical 4-chamber view, the apex is not well visualized. Apical 2-chamber view, we didn't recognize any LV clot, but when we inject in contrast, we found that there is an apical LV clot. So this is zoom view, and we measure it 1.1 times 1 centimeter. So this is one of the beauty of using contrast. Second case, 49 years old male has CHF, referred to our lab to rule out LV non-compaction. So in apical 4-chamber view, the technician is noticed that the LV is hypertrabeculated, and we need to prove it by injection contrast. So when we inject in contrast, we found there is a prominent trabeculation and deep recesses with thin compacted epicardium and thick non-compacted endocardium involving the apex and the lateral wall, with a ratio of the non-compacted to compacted layer 3:1. Then we do the in diastolic volume, we get 399 ml, in systolic volume 370 ml, and we get the ejection fraction by modified SHA-MC method less than 25%. The fifth recommendation, 3D data sets. And the first question that comes always when you are doing echo, why do we need a 3D in echo? What's wrong with 2D? And the simple answer is because the heart is 3D object. So we need an imaging to cover the 3D aspect of the heart. So to go and assess the function of LV by 3D and quantitative way of assessment again, we need to change our mind, because we get used to assess the LV function by eyeballs for many, many years. And we should do some quantitative assessment. And of course, the technology is going farther, and we should go. So in 2D imaging, we have only 2 dimensions. We have longitudinal dimension in blue, and we have the lateral dimension in red. But in 3D imaging, we have 3 dimensions. We have longitudinal in blue, and we have lateral in red, and we have the new elevational dimension that will assist the heart front to back or back to front. and how we perform 3D full volume. First of all, 2D images should be optimized because poor 2D will give me poor 3D images. Then acquire one full volume and go to software in the machine called 3DQ Advanced. So now here I have 4-chamber view here, I have 2-chamber here, I have short axis here, and I have the full volume here. So the first steps, we will do the alignment, and we should be sure that we are cutting the LV at the longest axis, so we do not foreshorten the LV, because the foreshorten, this is a problem that we have it with 2D. So the red line will crossing the apex to the base at the mid of mitral valve, and the blue line will be at the tip of mitral valve. Second, we will mark the wall. So this is septal, no doubt. This is lateral, no doubt. This is apex, no doubt. In 2 chambers, sometimes it will be difficult. So always take the anterior mitral leaflet and take the appendage. So any place I have the appendage, this is the anterior wall. Any place where I have the largest leaflet, this is the anterior wall. So I will mark here as anterior and here as inferior. So I have 5 points to be marked: septal, lateral, apex, anterior, and inferior. And in short axis view, always the yellow arrow should be pointed toward the mid of the septum. And we will do it in diastole and in systole, then the machine will compute it for us. So
1 minute? Just 1 minute, huh?
But I need 5 minutes more to complete the presentation. Okay. 5 minutes more. Okay, or 4. Okay, so I get in diastolic volume 93 ml, in systolic volume 26 ml, then I get the ejection fraction by the 3D full volume 71%. And this is the surface rendering where we will see the heart in a solid appearance. So the LV here divided based on the American Society of Echocardiography to 17 segments, and each segment will be represented by the curve down. So this curve will show me that each segment reached to minimal systolic volume, and this is time to minimal systolic volume or synchroni index. I get 2.4%, this is normal, up to 5 is normal, 5 to 10 is mild, 10 to 20 is moderate, more than 20 is severe desynchroni index. Okay. And at the end, it will give us a map here. Any area that is green or blue, this is synchroni. Any area that is red, this is delay. So 2% of delay, this is considered as normal. And what is the advantage of using 3D? There is no geometrical assumption and unaffected by foreshortening. And there is disadvantage, lower temporal resolution and image quality dependent. And the sixth and the last recommendation, global longitudinal strain. So what is a strain? Strain describes myocardial shortening. That is a fractional change in the length of myocardial segments. Strain can be positive or negative, which reflect lengthening or shortening respectively. And how to calculate it? It will be changing in the length divided by the initial length. Strain is unitless and expressed as percentage. And this is the latest recommendation in the guideline. Peak GLS in the range of -20% can be expected in a healthy person. GLS measurement should be made in 3 standard apical views and average, so segmental strain is not more recommended. And for serial GLS should be performed using the same vendor's equipment and same software. And this is the case, 25 years old patient with a normal heart. So this is apical 3-chamber view. We should get it with high frame rate, 71 frame rate. And usually to do the strain, we start with apical 3-chamber view because we need to set the aortic valve closure. And in apical 3-chamber, this is the only view that we can see the aortic valve. So the LV here will be divided to 6 segments, and there is number for each segment, which represent the segmental shortening. So the machine will calculate for me the segmental strain, and it will calculate for me the global longitudinal strain at this level, which is -20%. And there is color coded for each segment, which is represented by the waveform down. So the y-axis will be the strain, and the x-axis will be the time. And this curve will show me that each segment reached to peak systolic strain by these dots here, and of course the y line will be the average. So apical 4-chamber view, the global GLS at this level -22%, apical 2-chamber, the global GLS -21%, and this is the average between 3 levels, -21%. This is expected in a healthy person. And what is the advantage of using strain by specular tracking? It's angle independent, minimally affected by intra and inter-observer variability, and non-affected by cardiac translation movement. And it has this advantage that it's vendor dependent. And my take-home message, InMode has limitation due to geometrical assumption, but still useful due to high temporal resolution. Simpsons is recommended to calculate LV volume, but still subjective to LV foreshortening. Contrast is used for LV opacification, but should be used if two contiguous segments are poorly visualized in apical view. 3D is a new imaging modality, and we should use it. Strain is a good predictor for LV systolic function. And my take-home message for all of you guys, if you fail, never give up, because fail means first attempt is learning. End is not the end. End means effort never dies. And if you get no as an answer, always remember no means next opportunity. So let's be positive. Thank you.